Yeah, so I just wanted to inform the people that are joining that we are starting a webinar on the introduction to anemia by Dr. Paul. I will be sharing the slides with you, and after the session or during the session, please make sure that you ask questions. There's a Q&A section on the presentation. Please go ahead and ask any question that you think is vital to this presentation. Anything that Dr. Paul doesn't find an answer to at the moment, he always communicates back and makes sure that we get an answer to the question. Just to inform you, the Addis Clinic is happy to introduce our new executive director, Dalal Kob. Some of you will continue meeting her in different presentations in different areas. We will update our social media platforms, our websites. Please go and check them out. Dalal has a vast experience in global health, and she is very happy to partner to work with the Addis Clinic and working with this team. Actually, this is the first day that she's meeting Dr. Paul, and from there on, it will be a great interaction to have. Dr. Paul is one of our outstanding physicians on the platform that is always eager to help in case of anything. So just a small understanding, anybody that finds that they need more clarification, please reach out to me. I will post this recording to our the Google Drive. I will share it. I will share the link to the through SMSs. So for anybody that is willing to go back and refresh their memory on what we talked about during this session, or if you want to share the session, the slides with your colleagues or anybody in your group, please do so. I will share the slides in our Google Drive and share the link of the Google Drive. So it's 8 minutes, it's 10 minutes past 8, and I'm glad I will start the session. For everyone, Dr. Paul is taking over. Thank you.
Well, first of all, Anthony, thank you for your very kind words, and also for the people who are there. I've said many times how impressed I am by the work you folks do, the difficulty and the complexity of your patients, because when I get a question and I look at the type of patients you're seeing, I can tell you, because I've only basically practiced in Canada and the United States, you folks are seeing very difficult, very complex patients. Today we're going to talk about anemia. And the reason for anemia is I've had a number of questions about patients who are anemic. You know, how should we proceed? What tests should we do? How do we treat them? So the definition is a deficiency in our red cells, which carries, you know, oxygen. If you are anemic, a patient can present with fatigue, shortness of breath, and additional symptoms. Next slide, please. Next slide, Anthony. Thank you. Okay, we have done the definition. There's a number of types of anemia. Iron deficiency, probably the most common type. There's not enough iron for the body to produce sufficient red cells to meet our needs and our demands. However, there are other causes of vitamin deficiency. B12 and folate are the two essential vitamins for production of the red blood cells. And if we are deficient for whatever reason, of B12 or folate, we can also be anemic. So we can have sufficient iron, but still be deficient in B12 or folate and become anemic. Finally, the last cause is if we are producing enough red blood cells, we have enough B12 and folate, but the red cells are broken down too quickly. They're destroyed. And this is where there are some diseases, autoimmune diseases that cause it. There's some genetic disorders. So this is sort of a broad outline of anemia. And, you know, we have to become more specific when we get a patient to see what type of anemia they have. Next slide, please. Okay, so if we go again into the causes, if the bone marrow is not producing enough red blood cells, we become anemic. If we're breaking down the red cells too quickly, we become anemic. There's also blood loss. You know, women every month, when they're having their cycles, they're losing blood. And if they're losing more blood, and that, which is losing iron, then they're taking in their diet, they become anemic. If you have bleeding, you've cut yourself, a major cut, you're losing blood. You can have an ulcer, you leaving blood. A cancer, a tumor can cause blood loss. And that doesn't have to be a rapid blood loss. People who have cancer of the bowel or a bleeding ulcer in the stomach can have a very slow blood loss over time. And it's to the point where they don't really realize that something's going on until down the road they suddenly say, hey, I'm feeling more fatigued, more tired. I don't have the energy I used to have. And, you know, they're not thinking, oh, I may have an ulcer. I may have a tumor. I mean, that's our job when they present to our office to find out. And there are certain medical conditions. If our kidneys are failing, if we're having problems with an inflammatory bowel disease, cancer, as I mentioned, can all affect um, conditions which will lead to anemia. Next, please. Next slide, please, Anthony. Good. If you look at Kenya, because I want to know what are the most common causes for a patient in Kenya to become anemic: iron deficiency and malaria. Interestingly enough, in the United States, we rarely see malaria compared to the incidence that is presented in Kenya and other countries. And iron deficiency due to foods which are not rich in iron, and some of the foods that people eat in Kenya and other countries can affect in a negative way iron absorption. Next slide, please. Okay, so how do you feel if you're anemic, or what are your symptoms? Fatigue, probably the most common, and people can come in and just say, I'm feeling a little bit tired, or I'm feeling exhausted. And it depends on how they experience their anemia. So you can't look at a number and say, if you're mildly anemic, you're only going to feel a little bit fatigued. It depends on how the patient's experience. People with anemia can present with headaches. So a patient comes into your office and says, Doc, I'm starting to develop headaches. In your back of your mind, you've got to think, could this patient, as one of the many causes of headaches, be anemic? And that just helps us, as we will see down the road, decide what tests to do. Pale skin, um, especially when you look in the conjunctiva, where you see that there's pallor. Also, when you're anemic, our hearts have to pump the blood faster to get more oxygen to our tissues. So a rapid heart rate. So somebody who presents again with, gee, doc, I've noticed my heart is beating faster when I do something minor, when I go for a walk, when I try to work. That can be due to anemia, besides a problem that's basically with the heart or the thyroid or one of the other causes of a rapid heart. So again, it's something we have to keep in the back of our minds when patients come in with multiple symptoms. Next, please. Oh, good. Okay, so how do we diagnose? One is history. So when we're taking our history, we want to know about a lot the standard things we do. What's the past history? Has somebody had an ulcer in the past? Are they more likely to have another one? Are they taking a medication that can cause bleeding? Are they on a blood thinner? Are they on a medicine that could cause an ulcer in the stomach? Is there a family history? There are some types of anemia that run in families. Are other members of the family having anemia? Let's look at our physical examination. Are they breathing more rapidly trying to get more oxygen in to the fewer red blood cells? Is their heart rate faster? Are they pale? Do they look tired? And then, of course, the blood tests, which are the definitive way of knowing, what is the hemoglobin? And look at the red cells and look at other blood components. If we find out a patient is anemic, what should we do? An iron, a B12, a folate, looking for signs of infection. If they have malaria, we may have the answer just because once we treat the malaria and that will help, but then also we have to supplement them. Next, please. Okay, the CBC, very common test. We do it all the time to look at the size and shape of the red blood cells. It can tell us how severe the anemia is. And also, once we diagnose our patient as being anemic, we want to see how they're responding to our treatment. So I come into your office, you determine I'm anemic, you determine that my B12 level is low as my cause of anemia, and you start me on B12, however you decide to do it orally or by injection, you're going to bring me back in a few months and recheck. Am I responding? Am I getting the right amount of B12? Or if it was iron, am I absorbing the iron properly? My blood showing a positive change. So by monitoring your CBC, not only to make the diagnosis, but over time to see how our patients are doing. And one problem that I have, and I'm sure you have the same problem, is sometimes patients don't come back. And that's difficult because if they needed a higher dose of B12 or they weren't absorbing their iron or there's another process going on, sometimes it's difficult to follow up, but that's a separate issue. Next, please. Okay, what tests do we do? Let's look at the iron studies. So the serum iron is bound to a chemical called transferrin in the blood. So we measure the serum iron to see how much there is. We measure the maximum amount of iron that can be bound, is called the total iron binding capacity. We also look at this transferrin, this protein that carries the iron, how much of it is saturated or bound with iron. If it's low, if your transferrin saturation is low, then what happens is that there's room for more iron to be given to the patient. And finally, the ferritin, which is a way of looking what my iron stores are. Because as I'm producing iron in my bone marrow, the bone marrow has to draw on my iron stores when it wants to produce more iron. Now, hopefully, I'm supplementing that iron by my diet or sometimes by medication, by pills, to keep those iron stores up. So, one of the uh, guidelines that I was given is that all women who are having their cycle, their periods, should be given iron on a regular basis because they're losing it every month. And therefore, if they're not taking a diet which has sufficient iron, and diets vary all over the place, one way of helping ensuring that that woman will not become anemic is to give her iron. And as you may know, and we will probably touch on it again, iron constipates. So often when you say it to a patient, I want you to go on iron, what I always do is say, this may constipate you. Better you use natural treatments. Figs, and that, which will naturally help with, or extra roughage, help with constipation, rather than having to give a pill or artificially, stimulate the bowel. The more natural we can be, I think it's the better for the patient. And it's one, as long as they have the ability to get with their diet what they need. Next, please. Okay, vitamin tests, B12 and folate, um, simple blood test. I can say simple. I know that not every site in Kenya has access to every test that I'm recommending. Some sites you probably have to send it away from your lab if your local lab can't do a B12 or a folate. There's really very little risk. Once you, let's say you have a patient who's anemic, you're not worried about a cancer, you're not worried about a bleeding ulcer. You say, gee, their iron is low, but I'm a little concerned that their B12 and folate can be low. There's really almost no risk in supplementing those. They're water-soluble vitamins. So if I went to the store and I happened to buy B12 and I took extra, even though it's in my diet, I'm not going to harm myself. The same with folate. If I took folate as a supplement. So, if you don't have access to a B12 and a folate, and even an iron you can overload yourself, but B12 and folate you can't. There's nothing wrong with you saying to the patient, here, go. And I don't know about Kenya, but here in the US and Canada, they're really inexpensive. They're easy to get those vitamins. And if you tell the patient, take them, that's great. They're not going to harm themselves. And you can be assured that they have enough of those vitamins to make, to supplement if they become anemic. Next, please. Okay. There are sickle cell anemia, which you folks are familiar with, thalassemia, a G6PD deficiency. These are all inherited disorders. Patients have no control over it. Obviously, it's in the genes, but the family history can guide you to that. So they may not know, they may know about sickle cell, they may not, but probably they would. But thalassemia or G6PD, they may or may not know. They may know that family relatives have anemia, and that could give you, if you are able to test for these, sickle cell probably is the easiest to test for, you can look at to the causes of anemia. But there are other causes, and it depending, genetic testing in the US is much more expensive than doing a simple, iron level or B12. And I would imagine Kenya is the same. They're more expensive tests. And, if you're treating sickle cell, I'm sure you're aware of anemia can be a problem, as well as the others. Next slide, please. Okay, so how can you treat um, iron deficiency? Your supplements, and there are different forms of iron: the gluconate, the fumarate. I don't care, the sulfate. I don't care which one you're using. They're all going to give the body iron. The higher the dose of iron, the more likely you're going to get constipation. But it depends on how ill your patient is. If you want to build up their iron faster, you would use a greater concentration than if you're just saying, "Oh, you're mildly anemic. I want you to go and get this supplement." Now, if for some reason they can't take oral iron, or they're severely iron deficient, you can give intravenous iron. Now that involves them being in your clinic, that involves, monitoring them, but that's another way. If it's something that you feel is they're just borderline anemic, you can tell them, if it's appropriate, if they can get red meat, leafy green vegetables, and beans, all natural sources. And if they take vitamin C along with their vegetables or plant the beans, it increases the absorption or enhances the absorption of iron. So that's another simple way. Vitamin C, again, another harmless vitamin. You really can't overdose on it. And I don't know how many of you folks were familiar with Linus Pauling, who was a I think a British or an American scientist who felt that we should all be taking vitamin C for its additional benefits. So there's no, if you have a patient and you say take vitamin C, you're not going to harm them and they may get additional benefits. So these are just simple, there's a whole, you've got to look at your patient, you know how ill your patient is. If they need intravenous iron, okay, that's the way you go. Once you've got their iron levels up, you can move over to oral if they're able to take it safely. Next, please. Okay, and again, um, you want to monitor, supplement, and increase your diet. This is just a review of what we said before. So it's just a process that we go through. Next, I think. Okay, hemolytic anemia. This is where we're breaking up our blood cells. We're producing enough, but in the body there's something. It could be an infection, it could be a medicine we're on, it could be an autoimmune inherited disease. So the first thing we want to try and do is try and find out why that patient is anemic. And if malaria, as we said in an earlier slide, in Kenya is a major cause of anemia, if your patient has malaria, obviously you're going to treat the malaria, but if they present to you anemic, you're still going to treat the anemia. But if by treating the malaria, then you've treated the underlying cause. Now, when do you use a blood transfusion? There are guidelines, partly age dependent, but you've got to look at the clinical status of your patient. If your patient is coming in and they're really anemic, they're having trouble breathing, their heart rate is really rapid, their blood pressure is lower, you don't want to wait for oral iron or vitamin B supplementation to work. You want to consider a blood transfusion. One of my guidelines again is there's no place for a single unit transfusion. If somebody needs a transfusion, they should need at least two transfusions as a minimum. The patient that only needs one transfusion probably doesn't need it in the first place. So we're talking about patients who are more critically ill. And don't forget, while we are um, treating these patients. Often they're in hospital, they're at rest. We got to worry about blood clots and monitor them and prevent blood clots and other problems. We have to support them over the period of time that we're raising their hemoglobin, that we're giving them the blood level that they need. And once they're safe to be up and around, you don't need to worry about, you know, these type of problems. So this is sort of a general process. Next, please. Now, aplastic anemia is a really serious condition. Our bone marrow stops producing blood cells, stops producing. So, one, if you look at how you treat it, if there's an infection, you give antibiotics, you give them blood transfusion. There are immunosuppressive therapies that is given by a specialist. It's not something that I, as a primary care doctor, and I think you folks are the same, would want to be doing. And then the final step and the most aggressive step, but often life-saving, is a bone marrow transplant. So first level, we can give them antibiotics. I have no problems doing that. Blood transfusions, I have no problems ordering that. If we start moving into immunosuppressive therapy and bone marrow transplants, you have to be in a medical center where the doctors are skilled and have the knowledge and the equipment to monitor these patients, because that is really specialized care. So the steps 1 and 2 in this little pyramid here are really done in a specialized center. The initial ones, the patient comes in to see you and you're in a remote community and you think they have aplastic anemia, yes, you can treat an infection. Yes, you give them the blood transfusion, and then you reach out if it's hopefully feasible and get them into a specialized center. Next. Okay. What are the medications that we use for anemia? We talked about iron. We talked about B12 injections. B12 can also be given orally. When I started, I hate to tell you how long ago I graduated. When I started, 51 years ago, by the way, when I started, B12 was only by injection. If you had a patient B12 deficient and they were not absorbing it, every month they came back and they got their injection. Actually, we've had patients inject themselves, but now you can give it orally. And I'm sure there's studies that shows exactly how, compares the two, but you can give enough dose orally, saves the patient having an injection, saves the risk of infection with any injection. As you know, there's always a slight risk of infection, even if we're doing it properly. And finally, we can move on to using erythropoietin, which can stimulate red blood cells infection. And this is used in cases of certain cancers, chronic disease, where we have to stimulate the bone marrow to produce. And that, again, I would not order. I would send the patient to a specialist, a hematologist, because that is an area that is above my skill set as a family doctor. Next, please. Okay, blood transfusions. The quickest way of raising your hemoglobin. So you have a patient comes in, and I have seen patients or given advice on some of your patients who walk in terribly anemic. I'm so shocked at how often this occurs in Kenya, because when I was doing my training, and I rarely saw a patient which was severely anemic to needing an emergency transfusion. Unfortunately, with the experience that I've seen that you folks, it's much more common. There are risks of giving a transfusion. Don't forget, you can give too much. By giving a transfusion, you're giving the iron from the red blood cells. Not common to get an overload with too many transfusions. Got to be careful of an infection, that the whole process is done under a sterile technique. You can have a reaction to blood. And I remember once in one of the hospitals that I was in, it wasn't my patient, they gave the wrong blood. You've got to be very careful when you have a number of patients that when they take the blood, that they label it properly, the sample from the patient who they're going to give blood, that the lab makes sure they match a compatible donor to that patient so they're not getting the wrong type of blood. And there are different types of transfusions: whole blood, packed cells, or platelets. It depends on what the patients need. Packed red cells, I think, are probably the most common these days. It's a easier way of giving it less volume for the patient, and it does help. But there may be, if somebody's actively bleeding, you may want to be using whole blood in the emergency situation where you're going to be controlling the bleeding. And some people didn't need platelets to help control their bleeding. And don't forget, we have to monitor, we have to follow up how they did. So you give me a blood transfusion, I'm in hospital today. Tomorrow you want to check how I'm doing. You do my CBC and you say, oh, good, he's had 2 units, he's a little bit better, but he still needs another unit or two. And then the day after, you monitor it to see how I am doing. But that's what we do. I don't care what the condition is. So we're treating hypertension, we monitor it. If we're doing blood transfusions, we monitor. Next, please. Okay, dietary changes. We've sort of mentioned iron-rich foods, vitamin B12 and folate-rich foods, vitamin C. And you can get that naturally. You don't have to take, you can get it in citrus, fruits, berries, and make sure you're taking enough fluids, plenty of water and other fluids. you don't want your patient to be dehydrated. Next. Okay, supplements. We talked about iron. You can give a multivitamin which contains vitamins, minerals, including your B12 and iron. You can give B12 by injection, and folic acid is not injected, it's given by a supplement. But we sort of covered this in the past as just a brief summary of what supplements you can give your patients who are anemic. Next, please. Okay, follow up, as we've said a number of times, your blood test, check here that your iron levels are adequate. You don't want to saturate them with iron once they're normal. Then if it's a woman who's at risk of becoming anemic, you keep giving them a low dose of iron. If it's a male who's anemic, once their iron levels are normal, you stop the iron. There should be no reason for a man to be anemic. It's got to be a medical condition. It could be dietary, which is possible. It could be loss of blood. But if a man takes a vitamin with iron in it and they have, let's say, a slow growing cancer in their bowel or a small ulcer in their stomach, which is not causing symptoms, but it's just leaking a little bit of blood, you're going to mask that anemia from becoming recognized because you're giving them the iron that their body is losing. So no man should be taking iron. I'm not talking about a child getting the initial iron that they need, but once you're an adult, we don't need, as men, we don't need iron. And then um, you want to make sure that if you're going to say to them, please modify your diet, I'd like you to try and supplement your iron and your vitamin by, if feasible, if that's a diet that they can afford and that's available. Sometimes it's not feasible for a patient to eat a healthy diet economically, what's available, and other conditions. And then we have to modify things accordingly. Next. I think we're almost there. Okay. How can you prevent anemia in Kenya? I looked this up. Dietary strategies, public health, and that is beyond my ability, but I'm sure the government does work on education. I know you educate your patients. Food security is a problem worldwide, and I know that is a problem in Kenya. And then that's why you folks are there making access to healthcare. If it wasn't for your wonderful providers, people would have more problems than they do. You're available to help your patients. And so when a patient comes in, and even if they come in for something else, they say, doctor, I'm here for a headache or something else that's unreal. I'm here for a rash, and you're not worried about anemia, you take a look at that patient. And if in your mind that patient looks like they may be anemic, if you can easily do a CBC on them, you'll really help them. I don't want you to overdo CBCs, but just keep certain things in the back of your mind when you see a patient to look at the entire patient, not, I think sometimes we tend to focus on the problem. Oh, I was outside and I was bitten by something and I've got this, problem in my arm. You still want to just look at the whole patient and say had any other problems, because it's an opportunity that presented to you sometimes early in another problem. Next, please. Is that it? Thank you. I don't know
Yeah,
if there's any good. I don't know if there's any questions. If there are, Anthony, could you handle questions, please?
yeah. Let me handle the questions. So I think we had multiple questions, around 8 questions
Oh,
that
perfect. Okay,
come.
okay, let me also take notes because if there's a question that I don't have the answer, I will send to Anthony by tomorrow of an answer to any question that I just don't know, and then he will share it with everybody.
Okay. So the first question was, how does sickle cell disease cause anemia?
You're breaking up when the red cells are broken up during the fat when you go through a sickle cell crisis, you're breaking up your red cells and they're no longer carrying blood and you become anemic.
So the bone marrow is not replacing as fast as they are broken down.
Right. And they're more susceptible to anemia.
Okay, okay. I think that the one who asked that question, that has been answered. The second question, what are the best foods to supplement iron in the body?
Iron-rich foods, meats, um, iron-rich. I will send a list of iron-rich foods. That's probably the easiest way for you because I don't know again what is. I mean, beans are healthy, but I'll give you a whole list of iron-rich foods. And I don't know everything that's easily available there, but from the list, I'm sure you folks obviously do.
Thank you. I will pass it along when I get the list to everyone. So, can vitamin C be used by pregnant women?
Yes, for sure. No harm. It's vitamin C is water soluble. So if we take in more vitamin C than our body needs, we just in our urine, we just pass out the rest. So excellent question. No, very healthy and very safe.
Okay. So Felix asks, from a complete blood count, that is what we call, I think in Kenya, we call it a full hemogram. How can you tell
Okay.
the type of anemia based on the MCH, MCV, and MCHC? I think mean corpuscular hemoglobin, mean corpuscular volume, and mean corpuscular hemoglobin count.
Okay. Let me do the following for that one because I will send a list with what each of those mean. So I'll break down what you could each of them. Now you can't tell the iron level necessarily, but you can get an idea by send out the breakdown of the CBC or the cell types, the volumes, and what we can learn from each of them. So let me send that to you. That I think would be easier to do that way, and something we can have to look at.
Yeah, I think, Dr. Paul, I think something actually that can be discussed even in that discussion. If possible, you can write an interpretation of how to interpret a complete blood count from the top to the bottom.
I will do that. Or would you like also just a presentation on a CBC? That's easy to do too.
Yeah.
Okay, then that will be my next. I will send it, but I will also make it as a presentation for November. We'll do both.
Okay.
So the talk for November, if people are comfortable, unless you want something different, will be on CBC actually on interpreting blood tests, expanded a little bit more than just a CBC.
Yeah, yeah. So the
Okay,
next question
but
is,
I will send out. Sorry.
yeah, when you send out, I think it will be the next talk for next month.
Right.
At what
Next.
level of hemoglobin do you decide to transfuse blood?
I'm sorry, I missed that.
At what level of hemoglobin do you decide to
Okay, that's an
transfuse
excellent
blood?
question. I it depends, and I'll get you some numbers, but it depends on how ill your patient is. So if you have somebody who comes in, as I said, short of breath, rapid heart rate, low blood pressure due to anemia, I don't care what the number is, you want to transfuse it. Obviously, they're anemic. Um, Now, unfortunately, the US uses a different number system because we talk about grams of hemoglobin. So normal for a male is 13, but you use the metric scale, don't you, in Kenya? And
I think
I'm
we
not,
use both.
oh, you use both? Oh, that's beautiful. Okay. I give you a very personal example. I happen to have had a car accident and my hemoglobin fell to 7.2, which is down, but the guideline was 7 and below to have a transfusion. So I didn't get a transfusion. That was the surgical guideline after having had an accident. So it very, and I was stable. My blood pressure and that was stable. Um, but it depends on the situation, um, the rapidity of the blood loss. So if somebody comes in actively bleeding, um, we are trying to control, and maybe they're 8, but they've got a lot of symptoms. You use your clinical judgment, but I will also give you the guidelines for transfusion, um, because it does vary on how ill the patient is. Age does make a difference. If you have a really elderly patient, you're probably going to want to transfuse them sooner than if you have what was otherwise a healthy 25-year-old who suddenly was in an accident.
Thank you. Thank you. I think even in the next, in that context of transfusion, if possible, we can talk more about the reactions, the rhesus incompatibility, and everything else that comes along with transfusion.
Right. Okay, and I'll put that in the talk.
Okay. So
Great.
the next question is, I've seen people walk around in Africa, move and operate very well with an HB of 8 to 9 grams per deciliter. Is it something to worry about, or is it dependent on the race?
What could you I'm sorry to ask you to repeat that again.
So the participant is asking, is it dependent on the race, whether they are Caucasian or Africans, that sometimes you can see some black people working with an hemoglobin of 8 and they are comfortable, they are operating very well?
It depends not on the race, it depends on the clinical condition of the patient. So if a patient is at 8 and they seem okay, they're still anemic, you want to correct the anemic, they'll feel the anemia, they'll feel better, but you don't need a rush for transfusion. If they come in at 8 and say, I'm weak, fatigued, I'm get out of breath walking across the room, and the person is triggering angina because they're not getting enough blood through to their heart, that patient you're going to want to transfuse. So it depends on the patient and how they respond. So as I've used my own example, at 7.2, I was functioning. They didn't have to rush me to a transfusion. If I had had heart disease and I was developing angina, or my heart rate was 130 or 140, yeah, they would have wanted to transfuse me. So I think it's dependent on, that's what it's dependent upon.
Okay. So after that's answered, after how many hours or days do you need to recheck the CBC or hemoglobin level after a transfusion to confirm whether it's effective?
Yeah, you have to be. I mean, I would doing a transfusion. I would wait a day or two after it and recheck.
Okay.
That's a good.
So
Yeah, that from
there's
a
no,
transfusion now. Now, if you tell a patient, I want you to take this B12, whether you give it by shot or pills, and I want you to supplement from iron, and they're otherwise not having a problem. A few months later, you can bring them back.
okay. So there's no standard time.
There's no. It's really on your assessment of that patient and how you feel they are and what you need. You know, once you've raised the hemoglobin sufficiently in a patient that they're stable and they're comfortable, they may need another transfusion, but I'm not as worried once they're in a stable condition. I'm much more concerned when they're unstable.
Okay. So the next question is there anything like anemia of unknown etiology?
I'm sure there is, and I will find. As a matter of fact, I know there is, but let me give you more information on it because I know sometimes you can do a workup and you looked at everything that you can think of, and you don't have an answer.
Uh,
And it may be that we don't have the availability of a test we need, or we haven't thought of the right conditions. But I'll double check. I believe that you can still just do every possible test and come out without a diagnosis, and
okay.
then the question is, if all your tests are normal, the patient's still anemic, what do you do? And I'll find out the answer for that too.
Okay. So I think the last question comes from Effie. What type of anemia does a client on chemotherapy treatment have?
Uh, if it can be due to the chemotherapy can destroy or can affect the bone marrow, depending on the specific chemotherapy. So some of them can affect the bone marrow's production. On some of them, some of them will cause ulcers. It depends on the specific chemotherapy, how it reacts with the body.
Okay.
So I wish I could give you what it's not dependent. All chemotherapy can cause anemia for sure, but it's all not always the same mechanism or the same way of causing it.
Okay. Okay. So I think there's one last question.
Sure,
If a patient comes with low blood pressure, which needs
right.
immediate intervention and has severe anemia, but the blood is not available, can I give them fluids like normal saline?
Definitely.
What fluids?
Yes, definitely start them with fluids. And then as soon as you can get blood, if you can, you can, depending what studies you can get done, if it turns out that they're iron deficient, you can start giving them iron. If they turn out they're vitamin deficient, you start giving them the vitamins. And then as soon as you can get blood, if that's still needed, then you transfuse. Yes, I would give them fluids initially because there are in the US, and I don't know enough, there are certain groups who are opposed, it's a religious reason, who are opposed to getting blood. And that becomes a really difficult problem where you don't want to disrespect somebody's religion, but you know that the best treatment is. Now, there are some blood substitutes. I don't know how readily they are available. I did have many years ago a patient who had a ectopic pregnancy. And one of the risks of an ectopic pregnancy is internal rupture and internal bleeding. So we identified the pregnancy, and the family did not want to have blood and said that they would try and make arrangements to get for us through their sources a blood substitute. In this particular case, the surgeon went in and was able to do the surgery and no blood was necessary. We were fortunate, but the backup would be to use an artificial blood, which was acceptable to this particular group. So, that is, I don't know in Kenya, and even here in the US, it's not something that all hospitals carry by any means are blood substitutes. It's a specialized chemical, and I know nothing about it except that it exists.
Oh, okay. And on the same question by Asha, what fluids are recommended? Which type of fluid? Normal saline, Ringer's lactate, dextrose. Which is the most effective fluid?
Which is most effective? What, please, again?
Which is the most effective fluid according to the as you wait for transfusion?
Oh, fluid. Uh, I would use any fluid to increase. If you got, normal saline, depending what the blood pressure is, dextrose and water, whatever you have, you want to give them fluids.
Okay.
So whatever Ringer's lactate, whatever you've got easily available for that patient to, hydrate them.
Uh, so I think that was the last question, Dr. Paul.
Well,
And
thank you
I
so much.
think we are in time.
Yeah, I will send you'll have answers by tomorrow for your questions, and we will go from there.
Thank you. Thank you.
Thank
Thank you,
you so
Dr.
much.
Paul.
It was a real pleasure. Thanks a lot.
It was a real pleasure. For anyone that is in the group, I will be sharing the details of the meeting, the recording. We will upload them to our social media pages. We'll upload to our Google Drive. I will share the details. Some of you have managed to reach out to me, and in case you need a new topic to discuss about, Dr. Paul is always available. You can send it to me. Any discussion that you need for us to go about. My phone number is 0712-559-438. For anybody that would love to reach out and ask any question or pass a presentation, they would love Dr. Paul to tackle. My email is Anthony@addisclinic.org. So you can reach out to me via WhatsApp, via mail, via call, via text, and I will try and reach out to Dr. Paul to organize a presentation. Thank you so much, Dr. Paul, for the
Thank you
time
so
that you
much. It was a
allocate
real
to us.
pleasure. I'll see you again soon. Bye-bye now.